Part 4 of GI disorders is going to begin discussion on the congenital GI abnormalities, and this one is about cleft lip and palate. There are a lot of slides, but a lot of them are pictures. This just demonstrates the hard palate, where the pharynx is, and the soft palate. And I'll have that link on a Word doc that you can go and watch that. You can see on this child that they have a unilateral cleft lip. It's only on one side, but their palate is intact. And this is a child, an actual child who has it. And isn't he darling? This is a child who has a cleft lip and a palate, and you can see the difference here where the lip goes all the way up and it hits the initial part of the palate, and it's hard to see how far back it goes. So the upper lip is split, and this extends all the way in and affects the sinuses. When we do an assessment of a child with a cleft lip and palate, part of it is how well can they feed, because formula is going to come right out of their nostrils. And they have very poor suction, so they have to work so hard to get the formula down. On the lip, there can be a slight indentation all the way to a complete separation that goes all the way up into the floor of the nose. And then the palate can be just from the very beginning of the hard palate and then go all the way back to the soft palate and affect the uvula. And so you'll learn in 174 that part of our newborn assessment is always to put your finger in there and assess for a cleft palate, because they can have a cleft palate without a cleft lip. So this is an example of a cleft lip and a partial palate. So you can see that it's only affecting about 3/4 of the palate. This one is a full cleft lip and cleft palate, and it goes all the way back. This child has a bilateral cleft lip, and the palate is very wide and it is complete. And now be prepared, because I'm going to show you a bilateral cleft lip and palate on a child. And when you look at this little face and you think, oh my gosh, what if I had this child? Think about, what do the parents think when they look at this child for the first time? Will my child ever be accepted? And there are parts of the world that when a child is born with this defect, that they are completely ostracized from the community because they feel that this child has demons. So before we do a repair, dental is going to be involved, and they put a device in so that the child can have somewhat of a suction and that all their formula is not going to come out of their nose. They can tape the lip. We use a cleft palate bottle with a cleft nipple, and you can see that the nipple is a little narrower and a little longer. And remember from Skills Lab, that bottle is nice and soft, so that as we still want this child to suck, so as he's sucking, we're gently squeezing a little bit so that they can still get that suck, swallow, breathe down. You absolutely have to position this child upright to feed. Do not have this kid laying down. And there can be failure to thrive and respiratory complications if we can't get this kid to eat. And you know what? I am always so amazed at these mothers. They are experts. They finally come in to get their surgeries, and these kids are like in the 90th percentile. When you look at this picture, you can see the mother up on the top right. She has a device at the end of a syringe, so it's long, almost like IV tubing, only it's a little bit broader at the base. And it connects to a syringe, and so she's drip feeding that child. And now look at this guy. So even though he's had his surgery, look at how chubby he is. We definitely are dealing with psychosocial issues, feeding difficulties, potential for respiratory complications if this kid recurrently aspirates. And then as this kid goes through the repairs, not only is the sucking a potential issue, playing because they want to put everything in their mouth and we don't want them to, especially after surgery, but then the speech. This child is going to need speech therapy. So I'm going to clip through a few slides so that you can see some of the equipment. This is the Latham device that they insert into the palate, and you can see that they're tightening the screws on that so that they can try and bring it together. And what we do with this is we're going to just clean the extra mucus that accumulates on this device with a cotton tip applicator and water. And look at this little guy. I'm 6 months old tomorrow, getting my checkup with the plastic surgeon. Hopefully get this plastic thing out of my mouth. But other than that, I'm just kicking back and doing fine. And you see he's got a couple of chins there, so he's doing real well with eating. And that's our goal. This is a nasoalveolar molding device that they can use when it extends so far up the nose. And then I'll have this YouTube link on our Word docs. And note the defect the child has. Note how loving and supportive the family is. Note what the no-nos look like when we put them on their arms so they don't touch their face. And notice how happy this kid is. He doesn't know he has a problem. His parents love him and have cared for him, so he's a happy camper. And here's a little guy that's feeding, and he's got a cleft lip and palate. So the cleft lip repair, if it's only a lip and not the palate, then we have the rule of tens. 10 pounds, the hematocrit needs to be 10, and they need to be at least 10 weeks old. That's about on average. And they use the finest sutures on these repairs, and by the time everything is healed, you can hardly even tell that this kid had a cleft lip. It's amazing. And here's a picture before and after, and here's some more pictures. See how nice that looks? When you have these kids post-op, we want to prevent trauma as well as infection. They rarely get infected. And so we put these elbow restraints on, and basically what it does is it keeps the arms straight, and we call them no-no restraints. We want to avoid this child being in a prone position, and we don't want them to fall on their face. So really watch how you position them in the bed. For wound care, we're going to rinse the mouth after feeds, clean the sutures with sterile water, and they may or may not have an antibiotic ointment that we're going to apply about every 4 to 6 hours. Most of the time, they don't even use that. We still need to feed this child, so we want to put a nipple, or we'll use another device. We're going to slide that along the side of the mouth away from the sutures because you don't want to be directly touching them. And then we're going to use a soft nipple. We can use that a septo syringe, which is what that picture was that mom was using. And so it's got that long piece that extends all the way to the back of the mouth, and you can just drip it in. We do pain assessment and management. For the most part, these kids are pretty comfortable. And so Tylenol or Motrin is probably all they need, especially for the lip. And then child and family support and teaching. How are they going to take these same interventions and take this child home? When we talk about the cleft palate management, we would like to at least get started before this kid starts talking, because the absence of the palate makes it very difficult to say sounds. So they'll do the pharyngeal flap closure, and this is going to be in many steps. What we have to be careful with the cleft palate is not the bottle, because by 1 year of age, they're off a bottle. They're spoon feeding. And so you want to use a wide spoon. So if you were to feel your palate, the spoon should hit each side of the palate, but not be able to go up in the middle, because that's where the surgery is. So we use a broad spoon. We don't want them to suck on a pacifier. We don't want any kind of hard foods going in there. Everything is going to be soft. What kind of complications can they have? Well, they can have recurring ear infections, and along with that comes hearing loss. Definitely dental abnormalities. So when you look at that picture of that baby that I warned you about, the teeth are not in the right space. So they're going to be seeing a dentist as well as an orthodontist. We'll send them off to speech therapy. And then the psychosocial component is bonding with the baby. And what we like to do is show parents pictures of children who had the same defect. Show the before and after pictures so that they have hope that one day their child will be like that also. But they feel guilty. They wonder, the mother's wondering, what did I do that caused this? And we have no idea. There's also a form of grief because they've longed for this child and they didn't get what they wanted. Another thing they feel guilty about is that they birthed this child with this defect and this child has to suffer so much. but in the long run, they usually do great. So here's a little guy who had a beautiful repair. And so we're going to click through. This is little Stella, and she has a very big defect, so you can see where she is going to have dental issues. And here's her daddy. Oh my goodness, she's gotten the cheeks and the chin aplenty. And look at her. Look at that scar. Isn't that beautiful? She's getting ready for kindergarten. She's looking pretty good. She's going to audiology for testing her hearing, and you can see how her teeth are off to the side, and so she's going to need orthodontia. And look at this, a severe cleft lip and palate, and there she is, all dressed for the prom. So if you want to do some volunteer work, volunteer for the Smile Train. Go to the third world countries where these kids are not allowed to come into the village, because once they're repaired, that kid can come in and as though there was nothing ever happened. So this ends cleft lip and palate. Make sure you review your book too for the care planning about this disorder.